My name is Dave Shahian, and I chair the STS Quality Measurement Task Force and the Workforce on Quality. In this brief webinar, I'd like to describe an important change we're making to the methodology used to estimate performance scores and star ratings for the STS Composite measure for isolated CABG, the first of our portfolio of composite quality measures. I have no disclosures. Prior to 2007, quality measurement in adult cardiac surgery generally consisted of estimating one outcome, risk-adjusted mortality, for one procedure, isolated CABG. STS believed that a much more comprehensive approach to quality measurement was needed that embraced all the more common procedures. Also, using risk-adjusted mortality alone was felt to be inadequate for two reasons. First, with progressively falling mortality rates, it became more difficult to analyze performance differences among programs based solely on this one endpoint. And secondly, patients were interested in more than just surviving their procedure, but also whether they might experience a life-altering complication, such as a disabling stroke or kidney failure requiring dialysis. For some procedures, there were also evidence-based processes of care which could be measured and incorporated into a quality score. In 2007, after several years of development, the STS Quality Measurement Task Force published a two-part series of articles describing its first composite measure for the most common adult cardiac procedure, isolated CABG. This measure was estimated using 1 year of data, which at that time provided reasonable sample sizes. Bayesian random effects models were used, which included 4 domains: risk-adjusted mortality, the risk-adjusted occurrence of any of 5 major postoperative complications, use of at least one internal mammary artery graft, and administration of all 4 NQF-endorsed preoperative and discharge medications. Weights for these 4 domains were determined empirically from the reciprocals of their respective standard deviations. Outlier criteria were based on conservative 98% Bayesian credible intervals corresponding to a true 99% Bayesian probability that a center's scores were better or worse than expected. In a pilot study using 2004 data, 77% of participants were as expected, 10% were better than expected, and 13% were worse than expected. Notably, if risk-adjusted mortality alone had been used to classify outliers, only 1% of participants would have been able to be classified as 1 or 3 stars versus 23% using the composite. Over the ensuing years, multiple additional procedure-specific composite measures have been developed by the Quality Measurement Task Force, as well as multi-procedural composite measures at the individual surgeon and program levels. Recently, for a number of reasons, we have considered updating the methodology of the original isolated CABG composite. Isolated CABG volumes per hospital are declining, and case mix severity has increased. Because of smaller annual CABG volumes and the very conservative 98% credible intervals, fewer outliers can be reliably identified, and this limits the ability to discriminate levels of performance. This approach is also inconsistent with all other subsequent STS composite measures, which use 3-year data samples and 95% credible intervals. Some smaller programs, which consistently have superb year after year performance, have complained that they do not receive 3-star recognition because of their relatively small annual sample sizes. Conversely, it's possible that some consistently low-performing programs might avoid 1-star classification because of their small annual sample sizes. This limits their self-awareness and their incentive to improve, and it may mislead patients who are considering various providers. Our strategy in reevaluating the isolated CABG composite was to retain the basic methodology, but to explore several different analytic windows or data collection approaches, specifically the current 1-year approach versus rolling 3-year windows as used in all subsequent STS composites, a fixed number of cases such as the last 450, regardless of the time period, or a 450 case minimum, or 1 year of data for large programs that perform that many or more CABG operations in a year. We also explored changing to a slightly less conservative 95% credible interval as in other STS composites. This table shows the results of initial exploratory analyses. With the current 1-year 98% credible intervals, only 4.9% of programs could be classified 1-star and 6% as 3-star. This increases slightly when you move to less conservative 95% credible intervals. However, there is a major expansion in the proportion of both 1-star and 3-star programs when moving to either 450 cases, 450 cases or 1 year, or rolling 3-year windows. The increases were similar for these three alternative approaches, and they were more pronounced with 95% credible intervals as opposed to 98%. Based on these initial explorations, we elected to focus on 3-year data samples as the potential alternative to a 1-year analytic window, as this would be the most straightforward to describe and implement. We also plan to study both 98% and 95% credible intervals. These three cross-tabulations compare the current single-year, in this case 2017, data sample with various alternative approaches: single-year 95% credible interval, 3-year 98% credible interval, and 3-year 95% credible interval. Not surprisingly, the greatest increase in proportions of 1- and 3-star outliers occurred with 3 years of data and 95% credible intervals. Compared with the current 1-year samples and 98% credible intervals, the proportion of 1-star participants more than doubles from 4.2 to 10.5%, and the proportion of 3-star programs more than triples from 7% to 23.2%. The next several slides drill down to show the impact of methodologic changes in various participant volume category. This table demonstrates the effect of changing from 98% credible intervals to 95% credible intervals while maintaining a 1-year data sample. The proportion of 1-star participants increases, but the changes are exclusively limited to the 2 lowest volume categories. Greater increases were seen in the proportion of 3-star participants, especially among the 3 lowest annual volume categories: 0.3% to 2.3% in the 0 to 99 case category, and 3.3% to 11.3% in the 100 to 199 case category. If we move to 3-year data collection periods and compare the 2 credible intervals, there again were modest increases in the proportion of 1-star participants when changing from 98% to 95% credible intervals, and those changes were most pronounced among lower volume participants. The proportion of 3-star programs also increased when moving from 98% credible intervals to 95% credible intervals, but the changes were not as large as they were with single-year data samples, because in these analyses, the more important driver of outlier identification is sample size, in this case reflected by years of data. Notably, there is a monotonic increase in the proportion of 3-star programs as annual volume category increases in size. And by far, the highest proportion of 1-star programs was in the lowest 2 volume categories, all of which findings are consistent with a volume outcome association. Using 3-year analytic windows, this figure summarizes the distribution of composite score point estimates for each participant. The median CABG Composite score point estimate was 96.8%, with an interquartile range of 96.1 to 97.4%. Due to shrinkage, this may underestimate the true signal variation. Figure 2 depicts the estimated true signal variation across participants. The calculations average over all possible estimates for each participant. Median adjusted mortality was 2.3% with an interquartile range of 1.7 to 2.9%, and median adjusted morbidity was 11% with an interquartile range of 8.9 to 13.6%. Median omission of an IMA graft was 0.7%, interquartile range 0.4 to 1.4%, and median omission of at least one medication was 5.2% with an interquartile range of 2.1 to 11.4%. Rates of adjusted morbidity and mortality, IMA omission, and omission of at least one medication all decreased monotonically as star ratings increased from 1 to 3 star.
For example, 4.1% to 1.4% adjusted mortality, 16.6% to 8% adjusted morbidity, 2.6% to 0.5% IMA omission, and 17.6% to 2.6% medication omission. Reliability of the STS CABG Composite was estimated using 3 years of data and 95% credible intervals. Because of the increased sample sizes and endpoints, reliability was excellent at virtually all realistic levels of annual volume. Measure reliability using the 3-year window was significantly higher than for the current single-year data collection. For purposes of this comparison, credible intervals were set at 95% for each approach. In conclusion, the STS Quality Measurement Task Force has developed a methodological update to our original CABG composite measure, moving from 1 to 3-year analytic windows and from 98% to 95% credible intervals. These modifications address sample size concerns with the original approach in contemporary practice. They substantially improve our ability to identify high and low performing participants, and they make the CABG composite methodology consistent with that of all other STS adult cardiac composites. Thank you very much.